I will try to cover it under these following items. The femoral nerve starts from L2, L3, L4 anterior primary rami, moves in the abdomen, pass underneath the inguinal ligament, move in the thigh, go to the adductor canal, go to the leg, ends into the feet. So we can block the femoral nerve at a lot of sites. The first site, we can block it as high as the lumbar plexus. Near from its origin, we can block the femoral nerve, and if we look at in the lumbar plexus, we will include femoral and the obturator and lateral cutaneous nerve of the thigh. So we are going to block the three nerves. At the inguinal region, we are going to block the femoral nerve alone. If we do femoral nerve block at the femoral triangle. But we have two other blocks, what's called femoral 3-in-1, and we are injecting our local anesthetics at the inguinal region, aiming to go up here. That's why they call the 3-in-1. One injection and go proximally to include three nerves. The second block, we do it with ultrasound, and we see the femoral nerve and go lateral, and we inject underneath the fascia iliaca, and at this area we go proximally again, and we do block of three nerves. So at the femoral triangle, if we do just femoral nerve block, we block the femoral nerve alone. If we do femoral 3-in-1 or fascia iliaca block, we block the femoral, obturator, and lateral cutaneous nerve of the thigh, as if we are doing the lumbar plexus. For that reason, I use the terminology peripheral lumbar plexus. This terminology is not written in literature. It's described to remember that I'm going to block three nerves. If you go a little bit distant, I am in the adductor canal, and in the adductor canal, I'm going to block the saphenous nerve, which is a branch of the femoral. I'm going to block the obturator branch is going to the knee, the branches of the lateral cutaneous nerve of the thigh going to the knee, and I'm going to block one of the most important motor nerves, which nerve to vastus medialis, and this nerve to vastus medialis carry an important sensory branch to the knee. So adductor canal block, it is not a femoral nerve block. It's a plexus block. I'm blocking the femoral, the saphenous of the femoral, the branches of the knee, of the obturator, the branches of lateral cutaneous nerve, the motor branch to vastus medialis. Some people are going to ask me how this is a motor branch and giving sensory supply to the knee. There is an important law called Hilton's law, and this Hilton's law states any muscle moves around the joint, give a small sensory branch to that joint. Fortunately enough, the sensory branch of nerve to vastus medialis going to the knee is one of the most important sensory branches going to the knee. If we go a little bit distal, at the distal third of the thigh, we are going to block the saphenous nerve between the two muscles, the sartorius and vastus medialis, and here we block the saphenous nerve alone. So we have four sites to block the femoral nerve. At the lumbar plexus, it's with the femoral, obturator, and lateral cutaneous nerve of the thigh. At the femoral triangle, I can block the femoral nerve alone, or I can block the femoral with obturator and lateral cutaneous nerve of the thigh if I do 3-in-1 or fascia iliaca. In the adductor canal, it is not a femoral nerve, it's a plexus block, carrying the saphenous, the obturator, the lateral cutaneous nerve of the thigh, and nerve to vastus medialis. In the distal third, it's pure saphenous nerve block. So let's talk about the four sites of blocking the femoral nerve. I will start with the blocking of the femoral nerve in the lumbar plexus. Here we have two important muscles, the psoas major muscle and the quadratus lumborum muscle. And we have a lot of the branches coming of the lumbar plexus in relation to these two muscles. Here, if I'm looking from the back, here is the quadratus lumborum, and in front it's the psoas major, and in front is the abdomen. The nerves coming and the lumbar plexus present within the psoas major muscle. It divides the psoas major into anterior to third and posterior third. For this reason, I can call it a pseudo major block because I'm going to put my local anesthetic within the pseudo major. I can name it a lumbar plexus block because I'm going to block the lumbar plexus. So these two names are the same. Lumbar plexus block is the pseudo major block, and it's a very easy because I will scan from lateral to medial. I will bring my ultrasound probe vertically outside the transversal process. When I hit the transversal process, it's called paramedian sagittal because it's a vertical ultrasound probe, and transversal process because I'm going to see the transversal process. So this is my ultrasound very lateral, goes medially, it hits one transversal process of L4, more medially it hits the transversal process of L4 and L5, so I will see one transversal process, other transversal process, and in between space containing the psoas major muscle, and the lumbar plexus should be here between the posterior third and the anterior third. And this sign is called trident sign, and if I'm looking here, this is posterior third and this is anterior third, and this hyperechoic white area probably is the site of the lumbar plexus. The second place, blocking of the femoral nerve at the femoral triangle. And here we have two important fascia, fascia lata and fascia iliaca. And behavior of the fascia is totally different. Fascia lata moves above the nerve, the artery, the vein. But fascia iliaca, it goes above the nerve, then it blends and goes underneath the artery and the vein. So I have to put my local anesthetics just underneath fascia lata and fascia iliaca, and lateral to the nerve and above the iliacus muscle. So it's very difficult, and sometimes in extremely geriatric population, you cannot differentiate the exact location of the fascia iliaca, and if you inject your local anesthetics above the fascia iliaca, you will get a complete failure of the block. So personally, if I'm planning to do fascia femoral nerve block at inguinal region, I go inside the muscle and inject some local anesthetic. I find it inside the muscle, then I withdraw my needle out, inject, I'm still in the muscle, go out, inject. Once I find the muscle going down, so definitely I'm immediately above the muscle, definitely I'm below fascia iliaca. Here is the femoral nerve. So at this area, the femoral nerve does not give any branch. So here I'm blocking the all motor branches to the quadriceps muscle. Nerve to rectus femoris, nerve to vastus lateralis, intermedialis, and medialis. The four branches going, so blocking the femoral nerve at the femoral triangle, the patient is going to fall because I'm blocking the four branches to quadriceps muscle. So if you do femoral nerve block at the femoral triangle, you should put this mark behind the bed of the patient, because if the patient try to move, he will fall. And despite that, we have a very big geriatric population. They would like to micturate, they move from bed at night, they fall. So falling of risk is very important, and at the same time, delayed ambulation, delayed physiotherapy, delayed hospital discharge might be one of the major disadvantages of using femoral nerve block at the femoral triangle. And here, we have 5 patients who underwent total knee replacement with the spinal and femoral nerve block, all felt, and some of them need to periprosthetic fracture and need research. A lot of studies try to minimize the incidence of fall. So this publication used 2 groups. One, they used local anesthetic for femoral nerve block, and this patient felt, and the other, they put saline and the patient did not fall. So this is a cause relationship. Blocking the femoral nerve is the cause of the falling of the patient. Another study, they do higher block at the lumbar plexus. And as I said before, at the lumbar plexus, you will block the femoral, including all motor branches, the obturator. So the adductors will be weak. So the incidence of fall is much high. So this publication compared femoral nerve block at the lumbar compared to the femoral triangle, and the incidence of fall is much higher, which is more logical. In this study, they put the local anesthetic and the catheter above the nerve or behind the nerve. It doesn't differ and patient fall. Same degree of weakness, so it does not differ. Here, they use different concentration and different volumes, doesn't differ and patient fall. They compared continuous infusion to bolus, another study, doesn't differ to patient fall. So, doing the femoral nerve block at the femoral triangle, the patient is going to fall, delayed hospital admission, delayed hospital discharge, delayed physiotherapy. So some people saying that the femoral nerve block at the femoral triangle is dying, and others they said it's dead, and personally I say no, it is still surviving, and I tell you some indication for the femoral nerve block. To increase the success of femoral nerve block, sometimes you might find two arteries, because the femoral artery, as we see here, common femoral, then it bifurcates to superficial and deep branches. Sometimes this bifurcation, usually it occurs 1 to half centimeters below the inguinal ligament, but sometimes it occurs high in the abdomen. So in the lower limb, you will have two arteries, the superficial and deep branches. So if you do, and you see two femoral arteries, inject lateral to both of them to increase the success rate. You try to move your probe to see one artery, but if you fail, inject lateral to both arteries to increase the success rate. Okay? The second problem, the shape of the femoral nerve. It's called a pennant flag. Here is the artery, and the base of the femoral nerve is fixed to the artery. And as you go laterally, the shape is like a pennant flag, زي العلم اللي بيرفرف. فالعلم اللي بيرفرف, it might have different shape. It might be rectangle, might be like this, might be like this. So don't be confused to see different shapes. You might see like this, like this, like this, like this. So don't be confused. Anyway, you have to inject. The most important thing is aberrant femoral nerve. The femoral nerve in the femoral at the inguinal region is not a pure nerve. It's a fibers, a filaments. So sometimes you find some of them medial to the artery and some of them very lateral from the artery. So my advice is to do your scan. You see the artery, go lateral. Here I see one nerve, see I have to go more lateral until then I go medial. So now I can say this is the most lateral part of the femoral nerve in such patient. And here is another division of the femoral. So I have to inject here, I have to inject here, and here the fascia iliaca is very clear, and here is the fascia lata. If you see here the fascia iliaca, and it's come and it blends. As I am said, here the femoral nerve, I am seeing the femoral nerve here, but I don't see the most lateral edge. So I have to go with my probe more laterally until I see the most lateral edge. The fourth problem, sometimes you find an inguinal lymph node and you feel as if it is a femoral nerve. You have to go distal, you will not find the lymph node. But if you go distal, you will find the femoral nerve with an artery. So it's very important. And as I said before, this is the ideal target. I start by injecting within the muscle, go a little bit out and inject inside the muscle, go injecting here, I'll find the iliacus muscle going down. So I'm dead sure that I'm lateral to the fascia iliaca. The last thing, again, personally, I prefer to inject some of the drug below the nerve and some of the drug above the nerve to get what's called the donut sign. I will find my local anesthetics around. This lead to use lower volumes of local anesthetic, lead to you faster onset of block because this is a thick nerve. So when I'm doing femoral nerve block, personally, I do 2 injections, but again, you can use single injection and you don't need to search for such donut sign. I'm telling you later on why it's not dead. Some believe that the femoral nerve and the femoral triangle is dead, but I'm still saying it's still survive. At the adductor canal, it's called a mid-thigh block, adductor canal block, subsartorial canal block, or a Hunter's canal. In the mid-thigh, I will see the sartorius. It's like a boat. And underneath the middle of the sartorius, I find the superficial femoral artery, the saphenous nerve, and as you see here, it's a little bit going more lateral. And the femoral vein. It's between vastus medialis and adductor magnus. And between these two muscles, there is a membrane called vasto-adductor membrane. And this is very important because we have the vastus medialis and the adductor longus, and this is the vasto-adductor membrane and the sartorius. If you are injecting our local anesthetics underneath the sartorius and above the vasto-adductor membrane, is called a subsartorial block, and here there is a subsartorial plexus of nerves. But if you are injecting underneath the vasto-adductor membrane, it's called the pure adductor canal block. Personally, I say if you are injecting above the vasto-adductor membrane, the behavior is like an epidural. You get a delayed onset of your pain relief. But if you are injecting underneath the vasto-adductor membrane here, you will get a rapid onset. When you go in the post-operative with the patient with the catheter, you just inject 10 milliliters of 0.025 bupivacaine or 1% xylocaine. If you underneath, while you're still injecting the 10 milliliters, the patient tell you pain stopped. Very fast. It's like the spinal of the supraclavicular pectoral plexus block. But if you are here, you get a delayed onset. You have to talk to the patients 5 to 10 minutes, you get a pain relief. In my practice, I prefer to go and inject some of the local anesthetics above the plexus, above the vasto-adductor membrane, to include the subsartorial plexus. Then I pierce the membrane and insert my catheter and my local anesthetic in the real adductor canal. So the nomenclature myself here, I prefer to say adductor canal block rather than vasto. Here is the beginning of the adductor canal. So the nerve to rectus femoris to vastus lateralis and intermedialis are not blocked. So you just block the nerve to vastus medialis. This is very important because, as I said, nerve to vastus medialis carry an important sensory branch to the knee. Another important point that the nerve to vastus medialis, there are 4 nerves, but the nerve to vastus medialis accounts only for 8% of the muscle power. So when I'm blocking the nerve to vastus medialis, the patient lost only 8% of the motor power, not 25. So if you are talking about the potential advantages, in the textbook, the common position of the probe is horizontal like this. But if you put the probe like this, you will see the artery. But if you try to insert the catheter, you have to go with in the right angle. Sometimes it's difficult. Personally, I prefer to use an oblique approach. So the most lateral part of the row is going to be more cranial until I get the best same view, the same position of the artery, the same position of the plexus. So threading of the catheter in this oblique view is much easier. This is the oblique approach of the adductor canal. The main advantage of the oblique that the image is not changed. The point of entry is very high from the knee where I'm going to do the surgery. So if infection happened here, better than if infection happened here. The third point, we can do it very easily pre-operatively, and we can insert a catheter easily. As I said, if I'm doing femoral nerve block, I get 50% weakness of the muscle and patient is well. But if I'm doing adductor canal, I get 8%, which is the power of the vastus medialis. So we can say it's a motor sparing block. It's not pure sensory. It has some degree of motor, but it preserves a lot of the motor power so patient can walk and can do physiotherapy very early. The second thing, as I said, we are blocking the obturator branches going to the knee, the nerve to vastus medialis, the saphenous nerve. So adductor canal block is more than saphenous nerve block. So personally, I say it's a sensory adding. You will not find this terminology in the literature, but I mean by sensory adding, it's not pure femoral nerve block. It is femoral sensory branches of the femoral saphenous, the sensory branches of the obturator, the sensory branches coming from the nerve to vastus medialis, and even the sensory branches of the lateral cutaneous nerve of the thigh, which is the least important of them. The adductor canal is like this. It's like a boat, the hand of the boat. Here is the femoral triangle, and the begins the adductor canal, and the end there is the popliteal fossa. Because the end of the adductor canal is the adductor hiatus. The femoral artery coming here pass through the adductor hiatus and becoming the popliteal artery. So if we are injecting our local anesthetic into the adductor canal, it's a volume dependent block. Low volumes will block the saphenous nerve and other branches as been described only. Okay? But bigger volumes, this local anesthetic might pass through the adductor hiatus, going to the popliteal fossa and blocking the terminal posterior branching going to the knee without blocking the sciatic nerve. Unfortunately enough, this local anesthetic does not migrate proximally and don't do femoral nerve block. Although I am not sure of that, because some publications say it can go proximal. And personally, I should consider the worst of them. Here I'm injecting the dye at the adductor canal. This is done in our private clinic in Misr International Hospital. And as you see, this is the dye in the adductor canal. There is both proximal and distal spread. So you cannot guarantee that there is no proximal spread. The adductor canal is between these two green arrows. So I had been further subdivided into proximal adductor canal and distal adductor canal. And as you see here, we are seeing the nerves and vessel because the fascia in the proximal adductor canal is very thin, while the fascia of the distal adductor canal is thick, opaque, you don't see structures underneath. Here, they injected the drug in the distal adductor canal and they injected the dye here in 8 cadavers, and they found that all the drugs reached the popliteal fossa and they soak the terminal branching going to the knee without blocking the sciatic nerve. Another study inject only 10 milliliter in the distal adductor canal. Again, they go into the distal popliteal fossa. Here, this is a study in 16 patients, and they said that this injectate spread to the popliteal fossa, contributing to better analgesia. So injecting in the distal adductor canal can go distally to the popliteal fossa. So, do we have problem with the adductor canal? Yes. We have two major problems, the tourniquet effect and early ambulation. When we do the adductor canal, usually the surgeons put a tourniquet in the thigh and work with the tourniquet. So, putting a tourniquet in that area will lead to the spread of the local anesthetic along the whole length. So, earlier absorption, so the duration of action is less. Again, the early ambulation by the patients will lead to pumping effect. The muscles contract, again, lead to shorter duration. So the use of tourniquet and the early ambulation is associated with short duration of action if you are using a single injection. For that reason, I usually put a catheter almost for all patients undergoing knee, even patient going under knee arthroscopy. The possibility of proximal spread in this publication, there is spread both proximal and distal. And as in my work, there's both proximal and distal. So don't feel over safe. As we said, early ambulation is safe. But the initial first step should be attended by a nurse. And if the patient don't feel okay, the patient can move. The third problem is a vascular problem. As you hear, this black small area and this black small area, these are the genicular branches going to the knee. This is the vessels going to the knee. So if you go with your needle, you might go with your needle and inject your local anesthetic within this area and get a local anesthetic toxicity. Catheter can migrate and go into the genicular branches. During doing a ductal canal block, if you see genicular arteries, means that you are low, so go a little bit high, the genicular arteries. Here, as we see, another genicular artery, one here and one here. So these are two genicular arteries. This is the femoral vein. So if you go with the probe more proximal toward the inguinal ligament, you will find this genicular artery will merge inside the femoral artery. And when you do Doppler, you will find the genicular arteries and you have to see the vein. It's very important to know where is your vein, because if you are doing a ductal canal block, you will go with the needle from here to there. So, and you will go and you put your local anesthetic here. Sometimes this vein extends laterally. So if your needle coming like this and the vein underneath, you might go with your needle inside the vein. So you must see the lateral extension of the vein and go with the needle in plane, more lateral than the most lateral part of the vein. This catheter, as you see blood in it, we totally aspirate blood as if you are in arterial line, and we remove the catheter and we reinsert. Infection can occur, and here is the site of infection of adductor catheter, and in this patient, the adductor catheter has been left for a long time, more than 10 days, and this was the cause of infection. And again, the oblique approach, as I said, the infection is very far from the knee joint, so we don't afraid and we are not scared, and it healed with no problem. So we can say a lot of advantages of femoral nerve block. It can control pain in 85% of pain. Although the adductor canal block the anterior compartment, but femoral nerve can block 85%. Analgesia at the adductor canal equal femoral nerve block. There is a motor sparing, sensory adding. We can go and solve the problem of posterior knee pain that present in only 15%. If we would like to do sciatic femoral, we can do anterior sciatic approach from the same. We can insert a catheter. So a lot of advantage of using adductor canal with putting adductor catheter. If we go into distal third, we will find two muscles, sartorius and vastus medialis, and in between them an intermuscular plane. And this plane, we have two things. We have the saphenous nerve and we have the adductor tendon. Usually this hyperechoic structure is the adductor tendon. The saphenous nerve is too small to see it. We go in plane with the needle and we inject our drugs from one side. Some authors inject some of the drugs here and some of the drugs within the sartorius. Anyway, hyperechoic structure in this muscular plane is an adductor tendon, so make your needle away from it. Don't go opposite to such structure. We have 4 indications for the femoral nerve and nobody can say it's going to die. Fracture neck femur can also be solved with the adductor canal block. If you are doing below knee amputation, if you do adductor canal block, the patient can flex his knees during surgery. If you are using pure peripheral nerve block, so you can do femoral nerve block at the femoral triangle, so the patient cannot bend his knee. Especially this patient with amputated leg will not do early physiotherapy, as we said. If you do adductor canal block and on the second day the patient say, I'm suffering from severe pain, your adductor canal block is failed. Some say that the failure is due to failure to block these muscles, which contribute with its sensory branches to the knee. So this is due to weak problem muscular. So you have to block these muscles. You have to do adductor canal, to do pure femoral nerve block, and you have to accept analgesia and delayed hospital discharge, delayed early ambulation, and delayed physiotherapy. Again, the hip is highly innervated from 6 nerves: femoral, obturator, sciatic, femoral, obturator, sciatic, and other 3 nerves: superior gluteal nerve, nerve quadratus femoris, and lateral cutaneous nerve of the thumb. So these 6 nerves are important for hip innervation. So if you would like to do hip analgesia, you have to do femoral nerve block, and you have to do it at the inguinal region close from the hip joint. So these are the 4 indications that we still give the breath for the use of the femoral nerve block at the femoral triangle. So to conclude, adductor canal block carrying the following advantages: it is sensory adding, motor sparing, volume dependent, and can replace eye back block. I mean, can do posterior analgesia to the knee joint, easy catheter insertion with prolonged analgesia, motor sparing with early ambulation. Femoral nerve block can be used, is associated with quadriceps weakening, and still we need it for fracture femur, failed adductor canal block, and ankle surgery. I would like to say that here the fascia iliaca is above the nerve and below the artery and nerve. Here the vasto-adductor membrane is above the nerve, the artery, and you have to inject below the vasto-adductor membrane. And thank you very much.